chapter 68. We're going to talk about our kidneys and what makes them not work so properly. Acute kidney injury, or AKI, is basically the loss of your kidney function. It can affect the ability to maintain all of our normal processes, urinary elimination, fluid and electrolyte balance, and of course our acid-base balance. Kidney function can interrupt the activity of every single organ system, but primarily your immune system, endocrine, skeleton, and cardiovascular symptoms. Acute kidney injury is more common in the acute care setting or the hospital, whereas you will see more the chronic kidney disease in community settings like physicians' offices, clinics, things along those lines, or it can exist along with a different condition in the acute care symptom settings. Both types of kidney dysfunction, acute kidney injury and chronic kidney disease, can cause end-stage kidney disease, which of course reduces independence for the patient. It shortens the life and can significantly decrease their quality of life. So just a little bit about the pathophysiology. AKI, AKI is a very fast reduction in the kidney function. It results in a failure for the body to maintain the fluid and the electrolyte balance and the acid-base balance. This can occur over a few hours or a few days. Although your GFR for the most part is accepted as the best overall indicator of kidney function, when a patient has an acute or a critical illness like AKI or chronic renal failure, then it is generally not used in those circumstances. AKI doesn't only affect your kidney function, but it can also cause systemic effects and complications. There's a wonderful set of 4 tables on page 1412 you really need to look over, but just a few complications from acute kidney injury or hyperkalemia, hyponatremia. Just about, again, every electrolyte is affected. Patients can have nausea and vomiting, bleeding, heart failure, hypertension, pneumonia, sepsis, seizures, permanent kidney damage. So as you can see, just about every organ or system is affected. For the most part, AKI is caused by a reduced perfusion, and that is classified as your pre-renal failure. It's the most common cause of AKI in the acute care setting. Damage to the kidney tissue is the intrarenal phase, and that is where the body is starting to get injury to those glomerulus, nephrons, or the tubules. And the postrenal phase is when there is an obstruction of the urine flow, such as stones, tumors, things along those lines. Prerenal azotemia is nothing more than the retention and buildup of the nitrogenous waste in the blood. Basically, when things start, the kidney function is decreasing. They're not able to filter out those nitrogen waste, so that is the term azotemia. Toxins can also cause blood vessel constriction in the kidneys, and that leads to reduced kidney blood flow, oliguria, and azotemia. A couple of causes from this are hypovolemic shock and heart failure. With prerenal or postrenal, the kidney compensates by 3 different responses. It constricts the kidney blood vessels, that helps to activate the renin-angiotensin-aldosterone pathway, and then that releases the ADH, or the antidiuretic hormone. All of these three responses help to increase your blood volume and improve the kidney perfusion. But at the same time that it does that, the same responses reduce the patient's urine volume, which results in oliguria, which is a urine output less than 400 milliliters a day, and the azotemia that we just discussed, the buildup of the nitrogen waste in the bloods. It is possible for patients to recover from AKI. It's just important that it is caught early and the symptoms are treated. So, phases of acute kidney injury. There are several phases of AKI, which start with a rapid decrease in kidney function that leads to a collection of metabolic waste in the body. That's basically what AKI is. The first phase is the onset of the AKI. You have a reduction in the blood flow to the kidneys for any number of reasons, traumas, surgeries. There may not be a drop in the blood pressure. So as this reduction in blood flow is happening, the renin-angiotensin-aldosterone system is kicked in to provide the blood flow to the kidneys, and it's also helping the GFR rate. But if a patient is critically ill, then these mechanisms may not be working well either. The current guidelines suggest that a patient needs a mean arterial pressure, or a MAP, of 65 millimeters per HC to help promote kidney perfusion. Now there is a table on page 68.6. I will not require you to figure out the mean arterial pressure for a patient, but there is a nice table that's pretty simple, and you just need to know that patients need to have a MAP of 65 to have proper kidney perfusion. Blood lab results of patients who are at risk for AKI means that we're monitoring their kidney functions, that we realize that if they've got elevated serum creatinine, we need to be looking at those patients a little more promptly, communicating these observations to the physician so the interventions can be done to promote kidney health and to interrupt the progression of this AKI. Any of the surviving kidney tubules possess a really good ability to regenerate and proliferate or grow, so that's why it's really a good idea to make sure that we're identifying these patients promptly so that we can stop the progression of AKI. The oliguria phase, not all patients experience this, but the inflammatory causes of AKI can allow proteins to enter the glomerulus, and these proteins can hold on to fluid, and this actually can cause polyuria, or excess urine output. Now, during AKI with the polyuria, patients can have hypovolemia and actually have electrolyte loss, and those are the two main problems in the polyuria phase. The patient in the diuretic phase, which is when they're having all of this multiple urine going on, the plan of care for them needs to focus on replacing those fluid and electrolytes and monitoring them, taking vital signs, recording their INO, and then from there the result of the onset of the polyuria is actually the start of recovery from your AKI. So we want to be collaborating with our healthcare team members, make sure everyone knows what's going on, make sure whether we need to have these patients, drinking more, replacing those electrolytes, or whether if they've got edema and swelling, that we may need to do fluid restrictions. So these patients require frequent monitoring, close surveillance of INO, drug therapy, watching their nutrition, fluids, and of course any type of replacement therapy that they need. And this acute syndrome can be reversible if it's caught in time. We're going to skip hypovolemic shock for this particular lecture. So, chronic kidney disease. Going back to the other slide for one moment, renal replacement therapy is also called dialysis. You will hear most practitioners use the term dialysis. So for those patients who have a loss of kidney function, when we say renal replacement therapy, we're just stating that that is dialysis, and the dialysis basically does the work for the non-functioning kidneys. Some indications for dialysis includes uremia, neuropathy, any unexplained condition, a decline in the patient's level of consciousness, rapidly rising high potassium levels, or severe metabolic acidosis. Anything basically that compromises that tissue perfusion, then dialysis will be needed. So now we're going to talk about chronic kidney disease, which a lot of patients have, especially those patients that have diabetes. It's a progressive, irreversible kidney injury. The kidney's function does not recover. When kidney function is too poor to sustain life, chronic kidney disease becomes end-stage kidney disease. And now patients can live with this for months to years. It just depends on what other factors are going on in that particular person's life. Other terms that you will hear with chronic kidney disease are azotemia, which we've already discussed. Again, that's the buildup of the nitrogen-based waste in the blood. Uremia is all it is the azotemia with other signs and symptoms, and then uremic syndrome. And there's a table, Table 68.1 does a comparison of your AKI and your CKD. So the stages of CKD are reduced renal reserve, reduced GFR, and of course end-stage kidney disease. Your book lists 5 specific stages of chronic kidney disease, and I'm just going to give a little piece of all of the diseases. There is a chart on page 1419 that lists all of the stages and where your GFR will be at each of those stages. In your first stage, your patient may have a normal GFR, which is greater than 90, but you may have structural abnormalities like tumors or obstructions. The patient is at increased risk for kidney damage from things such as infections, inflammation, even pregnancy or dehydration at this point. So you would want to carefully manage conditions like diabetes, hypertension, or heart failure so that those disease processes do not cause additional work on the kidneys. In the next stage, which is mild CKD, your GFR is starting to reduce a little bit. It ranges between about 60 to 89. There is nephron damage that has occurred, and there might be some slight elevations of the metabolic waste in the blood because of the nephron loss. Your BUN, serum creatinine, and uric acid really are pretty normal in this stage. There can be an increased output of dilute urine, which means that your specific gravity is probably around a 1. That occurs at this stage, and then that can, because of the increased output, it can contribute to dehydration for this patient, which can start messing with your electrolytes. You can start seeing lower sodium levels, lower potassium levels. In moderate CKD, your GFR continues to reduce and is around 30 to 59. your nephron damage is getting greater, and you start seeing the presence of azotemia. Those metabolic waste are building up more in the system. Uh, we want to, at this point, make sure that we're trying to control the nephron damage, especially again with blood pressure control and blood sugar control. We might be needing to restrict fluids in the moderate phase, proteins and electrolytes as well. Over time, we get to the severe phase, that's the fourth stage, and then finally to the end stage kidney disease. By the time you reach the end stage, there are excessive amounts of urea and creatinine in the blood. The kidneys cannot maintain any type of homeostasis, and the fluid and electrolyte and your acid-base balances are just all really out of whack. And without dialysis, death can occur from end-stage renal disease. As the CKD continues to change, realize that you have healthy nephrons that are becoming larger and they're having to work harder. So your urine production and your water elimination are staying maintained. The homeostasis of your body is doing okay, but when about 3/4 of the kidney function is lost, this process stops. As the disease process progresses, the ability to produce that diluted urine is reduced. The kidney function continues to decrease. Your BUN starts to increase because your body cannot eliminate those waste, so then your urine output also decreases as well. At this point, your patient starts becoming at risk for fluid overload. Now, as we said before, CKD can affect just about every system, every acid-base imbalance, electrolyte imbalance in your body. So with the urea and the creatinine, your creatinine comes from proteins that are present in your skeletal system. How much creatinine excretion that goes on depends on a muscle mass. So if you've got a healthy male, then they may excrete more creatinine than a frail older person. It also can depend on physical activity and diet. For the most part, without changes in diet or physical activity, most people maintain their serum creatinine level. It's pretty constant. It is always partially excreted by the kidney tubules, and a decrease in the kidney function leads to a buildup of that serum creatinine. Urea is made from the metabolism of the protein, and it's also excreted by the kidneys. And your BUN level can vary a little bit depending upon how a person's protein intake is. Sodium excretion changes are pretty common. In the early stages of CKD, the patient is at risk for sodium depletion or hyponatremia because that there are fewer healthy nephrons in there to help reabsorb that sodium. So as the patient has polyuria, the sodium is lost in the urine. So polyuria of mild to moderate also causes sodium loss. As the later stages of CKD are going on, the kidney excretion of the sodium is reduced as the urine production decreases and we're going more towards oliguria. The body's trying to hold on to the sodium, and then we start getting high sodium levels or hypernatremia. And we don't have, even with a sodium intake in the dietary, the body still is not able to excrete it. So then we start having fluid and electrolyte balance problems. Sodium retention, remember, causes hypertension and swelling, so then these patients are starting to get a lot of edema. Even with sodium retention, the sodium level can appear normal because water is still being retained at the same time, so it's diluting it. And if fluid retention occurs at a greater rate than the sodium retention, you can have a false positive because everything's being diluted. So with the potassium, it's excreted mainly through the kidneys. Any increase in the potassium during the later stages can lead to hyperkalemia. This is one of those conditions that can lead to dialysis. Your normal potassium level is 3.5 to 5. So anything that is starting to reach up to 7 or 8 can quickly lead to a life-threatening problem for the patient. It can cause cardiac problems and rhythm results. Other factors that can lead to high potassium levels are taking medications that have potassium, the patient's not restricting the potassium in their diets, tissue breakdown, blood transfusions, and of course, if the patient is hemorrhaging. The acid base balances we already know are messed up due to the CKD. As more nephrons are lost, the acid excretion is reduced, and then you get metabolic acidosis. You have many factors that can lead to the acidosis. Your kidneys can't excrete the excess hydrogen ions, the acids. Normally, your tubular cells that are now damaged move the hydrogen ions into the urine to excrete them out. But ammonium and bicarb are needed for this to occur. In patients with CKD, the ammonium production is decreased and the reabsorption of the bicarb doesn't occur. So this leads to a buildup of hydrogen ions and a reduced level of bicarbonate. High potassium levels further reduce the kidney ammonium production and excretion. As the CKD continues to worsen, acid retention increases, you have increased respiratory problems, and the body is having to compensate for that. There is a pattern of breathing called Kussmaul's, which I believe is on our next slide. Kussmaul breathing or Kussmaul respiration increases with worsening kidney disease. You get Kussmaul breathing for an increased blood hydrogen ion level. It increases the rate and the depth of the breathing because the body is trying to excrete carbon dioxide through the lungs. And if you've ever seen a patient with Kussmaul respirations, it is just a very hard, heavy respiration. Other things that we will see are manifestations of a CKD. Every system is infected. You'll have hypertension, hyperlipidemia, heart failure, pericarditis. You'll have blood changes, GI changes. I'm not going to go into every single one of these because they are listed in your chart. In your book pretty well, but I will kind of hit the high points. So when we're talking in regards to neurological manifestations or signs and symptoms, things ranging from lethargy, seizures, coma can indicate the patient is having a uremic problem. As nurses, we need to assess for sensory changes, peripheral neuropathy, weakness in the upper and lower extremities, seizures, coma, and then of course when neurological problems are resulting, then we'll start using dialysis to help clear out the system. Cardiovascular problems, fluid overload, hypertension, heart failure, potassium, because the potassium levels are so high, you can get dysrhythmias in the heart, reduced sodium, water excretion, basic circulatory overload. If all of this is left untreated, then you'll see hypertension and pulmonary edema, and finally leading to heart failure. With cardiovascular signs and symptoms, you can also hear sometimes extra sounds, particularly the S3, irregular patterns, crackles, during lung auscultation means the patient can have a lot of fluid on their system and some shortness of breath as well. Respiratory signs and symptoms can vary. The patient can have deep sighing, yawning, shortness of breath. You want to observe their rate and rhythm. Look for tachypnea or hyperpnea, which is an increased depth of the breathing, and these occur if the patient's got metabolic acidosis. Again, you can see the Kussmaul respirations. That's an extreme increase in rate and depth of the respiration. You can also hear a pleural friction rub with a stethoscope. Patients can have a lot of pleuritic chest pain, and then again you can hear crackles indicating fluid overload. Patients can have anemia, abnormal bleeding, fatigue, pallor, weakness, which are indicators of anemia. Check for bruising, petechiae, mucous membrane bleeding. GI signs and symptoms: foul breath and mouth ulcerations, abdominal pain, cramping. Skeleton signs and symptoms: because of the poor absorption of calcium and the continuous bone loss. These patients have thin, fragile bones, so they're at risk for pathological fractures, even with just the slightest trauma. So we want to be handling these patients very carefully. Urine signs and symptoms. At first, your urine amount, frequency, and appearance can change. Then you can get protein or sediment or blood maybe in the urine. A few of the skin signs and symptoms: the pigment, because of the uremia, is deposited in the skin, so these patients can get kind of a yellowish color. They can almost look jaundice and or almost look like they have a faded suntan. With CKD, it interrupts a patient's quality of life. They can have a lot of doctor's appointments, a lot of treatments. So, as nurses, we need to talk to these patients about how they understand their diagnosis, what the treatment regimen means to them, whether it's medications, whether it's 2 or 3 days a week of dialysis. We need to assess them for anxiety, how they're coping, if they have family situations, if they have family members that can help get them through this. Because this can be a long-term process for them. There are many treatment options, but these patients may be going through uncertainties about where their disease process is going to lead them. Laboratory tests are the same as we've been talking about, monitoring the BUN, their sodium, all of their electrolytes, potassium, phosphate, creatinine, performing a urinalysis. In the early stages, the urinalysis can show some excess protein, glucose, red and white blood cells, and a decreased or a steady specific gravity. The urine osmolarity is usually decreased in the beginning. As everything progresses, the urine output decreases dramatically, and then your osmolarity increases. So we have a decreased urine osmolarity at first, and as that urine output decreases, your osmolarity will increase. In severe CKD, creatinine and BUN levels can be used to determine the presence and the degree of uremia. You have to be careful, though, about using these in patients that are, again, critically ill. Serum creatinine levels can increase gradually over a period of years. It depends, again, on the patient's muscle mass. Your BUN levels, something to remember, your BUN levels are directly related to dietary protein intake. So without any restrictions on protein, your BUN levels can rise to 10 or 20 times what they're supposed to be. These patients will need to be on protein restrictions if their BUN levels are elevated. Some of the imaging, chest x-rays, bone scans, specifically of the hand, can show renal bone dysfunctions. So those are the main things that we will see. That we can also do kidney ultrasounds and CAT scans. Priority nursing care, as I just discussed, or priority restrictions, specifically protein. Evaluating their muscle strength and energy, making sure they have a good family support system. If they have edema or they're fluid overloaded, of course, we need to restrict their fluids. Decreased cardiac output. These patients need to be resting to decrease the work on the cardiac system itself. The recombinant human erythropoietin, that's basically an injection that patients with CKD can receive about every 2 to 3 weeks. Realize that your kidneys make your erythropoietin, and that is the product that combines with the red blood cells and stimulates the red blood cells to be made in the bone marrow. So realize that there is an injection that these patients can receive to help their body make that erythropoietin again. The phrase, it takes a village, with patients with CKD, it really does. It takes an entire team, from the nephrologist to the social workers to physical therapy, and just a little bit of every discipline. There is a really nice concept map on page 1425 that really lays out CKD nicely. It would be helpful, probably. It puts everything on one page for you. But just to kind of recap a little bit of what I've said, management of this patient is going to include drug therapy, from diuretics to replacing electrolyte solutions, to possibly dialysis, managing the fluids. We have to obtain fluid balance and prevent complications from fluid overload. There's a good chart on page 1426 that tells you how you can manage fluid overload, from weighing the patient every day, making sure they're staying at a nice weight and not gaining a lot of weight, measuring their I&O, teaching the patient about the need to keep their fluid intake within a certain restricted amount, and then monitoring things like decreased urine output, rapid pulse, rapid shallow respirations. These things may mean the patient is becoming fluid overloaded. Looking at the amount and color of the urine, assessing the fluid status by doing the things that I just mentioned, fluid restriction if it is needed, and all of these things help to prevent pulmonary edema. Pulmonary edema can be a pretty severe disease process for a patient who already has chronic renal failure. We want to make sure the patients don't have any breathing difficulty. They don't have any crackles, wheezes. We want their oxygen saturation to remain above 92. Pulmonary edema results in a patient with CKD from left-sided heart failure, and that is related to the fluid overload from blood vessel injuries. In left-sided heart failure, the heart cannot pump the blood adequately from the left ventricle. It leads up to all this pressure in the left atrium and in your pulmonary blood vessels. All of this pressure causes fluids to start building up in the capillaries and in the pulmonary tissue, and that makes the edema. This condition can cause inflammation in the body system. It can cause a lot of fluid to leak from the pulmonary circulation into the lung tissue, and then it may eventually cause pleural effusion. Okay, so this is the reason why it's so important to help control CKD. Early signs and symptoms of pulmonary edema are restlessness, anxiety, a rapid heart rate, shortness of breath, crackles at the base of the lungs, and as pulmonary edema worsens, the fluid in the lungs rises. You may have increased crackles, decreased breath sounds, and the patient can have frothy, blood tinged urine. So, as this continues, your patient can become diaphoretic and cyanotic, and then we're talking, patients that need to be put into the ICU. These patients need to be in a high Fowler's position. They need oxygen. They need diuretics, IV Lasix, and then realize too that any type of kidney impairment puts the patient at risk for ototoxicity, which is ear damage with hearing loss. Okay, we want to control the pain associated with this, so a lot of physicians will be prescribed IV morphine, but again, we also have to be careful monitoring those vital signs with these particular patients. Um, so I think I've about talked enough. Just one last thing, um, just a couple of medications. Patients who have a long history of hypertension are at increased risk for CKD. These patients need to be on calcium channel blockers and ACE inhibitors. ACE inhibitors are the most effective drugs to control and slow the progression of CKD in patients with hypertension. They also offer cardioprotective factors to the heart. Calcium channel blockers can improve the GFR and blood flow within the kidney. Okay, you have several other slides in this particular unit. We are not going to go over hemodialysis or peritoneal dialysis in this unit, so for all practical purposes, this is the end of the unit, but please look over the questions and the case studies. Thank you.